You're listening to Case by Case, the podcast where medicine meets real-world practice, one clinical case at a time. Brought to you by a continuing education company, this series brings you front-row access to compelling case studies recorded live at top-tier CME conferences across the country. Each episode, we dive into a single, real-life medical case presented and discussed by leading experts in the field. It's medical education, elevated, engaging, and deeply relevant to today's practice. This is Case by Case. Let's begin.
All right, our active and final case, a 54-year-old gentleman presenting to clinic to establish care in the setting of a family history of premature CVD, has obesity, prediabetes, CKD. This may make you think of this new CKM construct, the cardiovascular kidney metabolic construct. Denies tobacco, alcohol, is on lisinopril 10 for hypertension. Still, the blood pressure there is not totally optimal, 139/82. And you see the lipid profile with the total cholesterol being a bit elevated, HDL a little low, LDL in a moderately elevated zone, and triglycerides also moderately elevated. And then we have a 10-year ASCVD risk by the pooled cohort equations of 9.7%. Now, we've talked about prevent, and I think we made it very clear that although this is, you said it really nicely, that it's a equation or equations in search of a guideline. So these are in the process of being incorporated into treatment recommendations. But if we were to plug in the patient into prevent, then we would expect to get a lower score, right? Because we talked about that it tends to be 40 to 50% lower in terms of its risk estimates because it's been recalibrated to modern populations. And then if we take into account the optional factors, if we happen to have those data, that could then further lead to adjustment in the prevent calculation. Let me go back and just point out that you see there at the bottom, it says risk of CVD, risk of ASCVD, risk of heart failure. So as we were talking about earlier, the one that's equivalent to pooled cohort equations is the middle one, the risk of ASCVD. So just be cognizant of that as you use it and try to compare, and as the new guidelines come out. This is a bit of an implementation challenge that the American Heart Association and others are going to have, is trying to make this super clear based on what clinical decision you're making, which output of the prevent equations should be used.
I think that the even bigger hurdle is going to be the propose, or what you've been alluding to, shift in cut points for treatment. There's been a lot of noise in our space that this underestimates risk, and people are all going to be stopping their statins. Right. And as you pointed out, that's probably not going to happen because the bar will be lowered.
Yeah.
But it's going to be an adjustment to a calculator, an adjustment to new levels too.
Yeah, exactly. So, I mean, along those lines, if you're currently using a 7.5% for pooled cohort equations, the prevent ASCVD equivalent would be around 5%. And if you're using that 5%, which is the, 5 to 7.5% is the current borderline group by pooled cohort equations, the equivalent by prevent ASCVD would be around 3 to 5%. So this is just reinforcing that it has the base equation with largely factors that have been used previously in the risk estimation equations, and then adding on these 3 additional factors. They're not required to calculate, but if you have them available, they can be used. And the AHA, I understand, is in the process of working with health systems to automate this the way pooled cohort equations are automated. I know you mentioned earlier with your trainees that are there with you in clinic, like you're pointing out to them, it's there, it's already automatically calculated, and it works really well. I guess how many folks in your current clinical practice have that the pooled cohort equations already automated in your medical systems?
Oh, the pooled cohort?
Yeah.
Pooled cohort.
Yeah.
Yeah, that was done a
Epic.
while ago.
In Epic.
I guess, we have Epic too, and it's already there. So hopefully that'll be the case that you don't actually need to go to the HA website, that this will just be there in your health system. But pay attention to the output, making sure that it's the correct output that you're using for the clinical decisions that you're focused on. In discussing this with Dr. Basile ahead of time, we wanted to just point out in particular that PREVENT brings in social deprivation index, which is a measure that you can get out quite easily by it just from the zip code that the patient lives in. So if we calculate PREVENT via the base model, adding in this patient's BMI, and of course a BMI of 32 is pretty common in many of our patients, and an estimated GFR of 94. Here, if we look at the ASCVD, we would get 5.6%. So you notice that's quite a bit lower than the 9 point whatever percent that we had earlier. That's for 10-year risk, but if you look at the 30-year risk, it's much higher, 25%. And then if we further expanded to put in these additional optional metrics, the zip code I put in there is the zip code for Johns Hopkins Hospital where I work.
Yeah.
There you see it, they don't move the needle a ton. There we end up bumping it up a little bit to 6% for 10-year risk, and the 30-year risk is really just interestingly just a tiny bit lower. So,
And it's interesting, like if I put in the zip code for Bellevue,
yeah,
across the street are luxury high-rises.
right.
You know,
You're
so
what?
Right.
across the street from Bellevue Hospital is luxury high-rises. So you have to be very
I
cautious
told you that.
about, the zip code
Yeah.
and how it might
Railroad.
change it. Yeah.
Right. My zip code back in the day, I think it was 21218. So that's the hospital.
Yes.
And the hospital's in a much worse area than the undergraduate school.
Yeah.
So, yeah, and it can make a difference.
Yeah.
The other thing is it's 30 to 70 instead of 40 to 70, right? They've lowered the range, I think.
Yes.
Yeah. And it adds heart failure. Yeah.
Yeah. So this current output that I'm showing here is the ASCVD output, excludes heart failure, but we also could get the heart failure output. And if you then add heart failure together with ASCVD output, you get the total CVD output. So notice here, if we use PREVENT and let's just say this was a simple case and we need to decide if the risk is 7.5% or higher, we would have said yes, eligible by PC, not eligible by PREVENT. So this is a case that exemplifies that JAMA paper that I showed, that if you use PREVENT, you then have millions and millions of people that then would no longer qualify based on the 7.5% 10-year threshold. So it's very important to recognize that those thresholds will be adjusted in the forthcoming guidelines to calibrate to PREVENT. So this leads us to our question: according to the ACC/AHA cholesterol guideline, which risk category is most applicable in this patient? Try to think back to that 9% pooled cohort equation risk that we put forward. Is it low, borderline, intermediate, or high? Okay, so so this patient with the 9% is in that 7.5 to 20% range, or 7.5 to less than 20%, 19% range that's considered intermediate risk. I know we didn't necessarily talk about that a ton in the prior slides. So this is a bit of a more challenging question, but that's where this pooled cohort equation lands for this patient, which is an area where starting the statin would be very reasonable based on clinician-patient shared decision-making. If the pooled cohort risk had been above 20% or above, that would have been considered high-risk primary prevention. Okay, next question. According to the ACC/AHA cholesterol guideline, which initial treatment strategy should be considered for this patient? Is it lifestyle only, lifestyle plus moderate statin, lifestyle plus high intensity, or lifestyle plus high intensity statin and ezetimibe? Okay, great. So I don't know that there's that B is 100% perfectly, that is what you must do, but that's aligns with the current guidelines. 73% of you said that lifestyle is the foundation of prevention. Starting a moderate intensity statin could be quite reasonable. And just to look at what our current guidelines say, specifically, this patient is, if we follow the chart down into that kind of the middle right portion where it says 7.5% to less than 20% intermediate risk, we do the shared decision-making, risk discussion, and at that point, we would favor initiation of a moderate intensity statin therapy. That's a class 1 recommendation. Now, it's possible that as you consider additional information, you could justify more aggressive treatment, but that's the starting point based on the guidelines. This is what the guidelines say as a class 1 recommendation based on level evidence of B non-randomized data for the risk calculation, that in primary prevention of clinical ASCVD in adults 40 to 75 without diabetes and with an LDL of 70/189, 10-year ASC risk of a hard ASCV event should be estimated using the pooled cohort equations, and adults should be categorized. In this case, this patient's categorized as intermediate risk. And then in adults at intermediate risk, statin therapy reduces risk of ASCVD. And in the context of a risk discussion, if a decision is made for statin therapy, you would start with moderate intensity statin therapy. In intermediate risk patients, LDL levels should be reduced 30% or more, which is consistent with a moderate intensity statin. And for optimal ASCVD risk reduction, especially in high-risk patients, levels should be reduced 50% or more, which is something, if you found the high calcium or something else that clearly made this a high-risk person, you go lower there. I'm curious, maybe this is a point where it'd be interesting to know, Dr. Unberg, what you're doing, because in talking with other colleagues, it seems like this evidence around moderate intensity statin therapy plus ezetimibe is leading to inclination to not necessarily ramp up the statin dose more to high intensity, but to go, if you did want to go more aggressive, to add on ezetimibe based on some of the data coming out of
Yeah, I mean, I've been doing that for a long time because if you look at the efficacy and safety curves of statins, what happens is as you start doubling the dose, the efficacy curve flattens. And the safety curve gets a lot steeper. So going from 40 to 80 of atorva, from 20 to 40 of Rezuva versus adding ezetimibe at that point, it's often better bang for the buck, so to speak. And so we've been doing that for a long time. Also, there are some patients that just have to be more hyperabsorbers. Patients with FH absorb more cholesterol, and you get these hyper responses to ezetimibe. So it's sometimes interesting to see what happens at that point. You might get more than the 15 or 20%. You could get a 30% response. And so it's the issue becomes, if you're thinking about adding a PCSK9 inhibitor, will that ezetimibe push you below 100 or below 70, and then it becomes more difficult to get it? Then the guidance now has given us the wiggle room to do the PCSK9 inhibitor and then add the ezetimibe. But those are my thoughts.
Yeah, totally agree. I guess it has some parallels to the antihypertensive world where there was a kind of more options for combination therapy. You get more bang for your buck from that versus going up on the dose. For a while in the lipid field, we didn't really have the luxury, and that's why there was such a push towards high intensity statin. But as you said, if you double the dose of a statin, you expect on average only a 6% additional lowering of LDL, whereas if you add ezetimibe, that's 18% or so LDL lowering. That's equivalent to 3 doublings of a statin dose. So I think for that reason, we're going to see more and more push towards combination therapy rather than always making the next step to. It's not a big intervention to go to double the torva from 40 to 80. That's
And
or
people
from
like
20 to
that.
40.
People like that because they're on one drug. But then you're seeing them back in another 2 to 3 months, and that becomes 6 months. And so I've just started to get a lot more aggressive a lot sooner. I find when their LDL goes down a lot, they feel really good about it, and they're more likely to take it. So I agree with you. Absolutely.
Well, I mean, the parallel is exactly the same. We would start with, let's say, lisinopril 20, not where you need them. You could add amlodipine or HCTZ, single pill combination, or with an ARB and single pill. But then they're still not where you want them. You'd go up with the combination. So you might end up with benazepril, amlodipine 40-10. What you're saying is that in the outcomes and in the LDL reduction, moderate plus ezetimibe equals high dose. But if you're not at your target with the moderate and ezetimibe, why not go to the high dose in ezetimibe?
Right.
They didn't have any statin problems to begin with. They're not charging you, for the most part, for the statin.
Right.
There's no copay. I mean, with my insurance, there's no copay for Atorva. Ezetimibe costs me $15 a month. Well, $15 for 90, $5 a month. So, you know, this idea in people that might have a problem going to the higher dose, I could see that, but why not go to the high dose with the ezetimibe and get a little more LDL reduction?
Yeah, the lower the better. You're right, and you're right. The cost is a big factor here. Now that we have generic statins and ezetimibe, it's really allowed for this strategy more and more.
I think that all those studies that are showing moderate dose with ezetimibe is equal to high dose is great for those that have trouble accepting statins.
Yes.
Which is very unfortunate.
I mean, there's some great data that was just published. I think you're probably referring to the Sweetheart data, looking at folks discharged from the hospital who have no ezetimibe, early ezetimibe, or late ezetimibe added to their statin. And the outcome curves completely track the addition of the ezetimibe. And the sooner you add the ezetimibe, the better they do. It's registry data, so it is what it is. It's not a randomized controlled trial, but it's compelling.
Yeah, that is something I like to do in patient. In the second case we had presented, she had had her ezetimibe added at that time of the second MI and then the PCSK9. The slides here are just reinforcing the recommendations from the guidelines around the option to use risk-enhancing factors if there's uncertainty around decision-making, and these would not be used to downgrade risk, but there are extra reasons you could go towards initiation of statin therapy if the patient's hesitant. And this is all in the context of a clinician-patient risk discussion. These are, this is the list of some of those key factors which, you know, really tie in with this new CKM framework. The factors include metabolic syndrome and CKD, and a number of factors that have been seen in the case that we just discussed in the prior ones. Okay. This next slide reinforces that some of these are measures that they're not saying that you necessarily have to measure these, but if you happen to have this information available, it can be used as a risk-enhancing factor. The ApoB level that was chosen is quite a high level. As they say there, that 130 equates to an LDL of about 160. And then an ApoB of 140 equates to an LDL of around 190, an FH level. So these are pretty high ApoB levels. But if you happen to see that, that could be further evidence to move towards statin therapy. Okay, so after clinician-patient discussion, the patient's hesitant to initiate statin therapy. What else would be helpful to assess the risk and aid in decision-making? Is it LDL subfractionation, a coronary artery calcium score, carotid intima media thickness, or all of the above? Okay, great. So that was the answer I was thinking of, coronary artery calcium scoring. For those that said all the above, I would say LDL subfractionation, as the NLA expert panel noted, there's not really great standardization of that or data for its clinical utility, so you can kind of skip that. It's just a distraction. And then carotid intima media thickness is something where there's also not good standardization across labs, and it hasn't shown great clinical utility. It's actually been quite confusing, some of the results that came out in lipid trials that use CIMT, so you can skip that as well. Not to say that a carotid ultrasound that shows overt plaque could not be useful. I do think that that could be useful, and you can see probably acknowledgement of that even more so in future guidelines, but don't look for CIMT data. Those just aren't well standardized from lab to lab or reliable.
I would add one other thing about the LDL subfractionation, which is that what a lot of people don't realize is that on lipid-lowering therapy, what happens is cholesterol is removed from particles and they become smaller. And so what happens is sometimes patients will go and get this testing done and then come to me and say, look, my particles are getting smaller. Small particles are bad.
Right.
And I go, no. I said, when you're on cholesterol-lowering drugs, the particle size does get smaller. And particle size is a meaningless metric on lipid-lowering therapy, and probably not even a useful metric off lipid-lowering therapy, because when you adjust for size, it's all about the number. So I agree with you. It creates more crazy discussions and useless testing. I don't do it.
That's a great example of how it can be a distraction. It can be not only is it not helping, but harmful to care if that then leads the patient to have this desire to kind of back off based on a faulty metric. Okay. The guidelines say an intermediate risk or selected borderline risk adults decision, if the decision about statin use remains uncertain, it's reasonable to use a CAC score in the decision to withhold, postpone, or initiate statin therapy. So you can use it as a shared decision-making tool if in intermediate risk adults or selected borderline adults in whom a CAC score is measured, for the purpose of making a treatment decision, and if the calcium score is 0, it's reasonable to withhold statin therapy. Typically, we would say then you could repeat it in about 5 years. If the CAC score is 1 to 99, it's reasonable to initiate statin therapy for patients who are 55 years of age. And if the CAC score is 100, or this is where the percentile comes in, notice there's no age criterion here, but if it's 100 or more or above the 75th percentile, it's reasonable to initiate statin therapy. So you could have somebody with a very low CAC score who's 40, but they have a high percentile. That would be a good reason to initiate statin therapy. This again is the algorithm that you've seen again and again. This might be the most common slide shown today. The CKM stages. I thought it was interesting that this patient does have this evidence of CKM factors. I think the BMI we said was 32. Plus they have risk factors, so they're entering into that stage 2 CKM category. If we measure the calcium and it comes back high, then they could be in that stage 3 CKM.
Thanks for watching. If you found this discussion valuable, be sure to like, subscribe, and hit the bell so you never miss a new episode. To explore upcoming CME conferences and earn credits while staying at the forefront of medicine, visit cmemeeting.org. Until next time, keep learning, case by case.